So let's go ahead and we'll get started with this week's seminar. I'm glad that everybody's here to join us. On behalf of the University of Victoria and the School of Health Information Science, we acknowledge and respect the Lekwungen peoples, the Songhees and Kapusim peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the university and the land continue to this day. Many of us are joining from other locations, and I encourage you to think about the land that you are currently on and the relationship you have with both the land and the peoples of that land. And I'm really excited for today's talk. It's also on virtual care, which makes sense given our current mode. And I've just let you know, for those of you who are new to our webinars, that you can use what's called the Q&A button rather than the chat session. So we are going to take questions at the end, but that doesn't mean you have to wait. You can type those in as we go. Just remember, if you're typing in the middle, give a little context for that question. So rather than say, what did you mean on that? You probably want to tell what slide it was on when you actually said that question. And so we'll have plenty of time at the end, and encourage you to write in those questions as we go. And without further ado, I'm going to go ahead and I'll turn it over to you and let you get started.
Thank you so much. And I'm so pleased to be part of this wonderful seminar series and also on the important topic that you have opened up today on virtual care and digital health solutions and how I will say health systems are actually coping with the navigation of integration within practice settings. So I'm going to share my screen if that's okay, and we can get started. Part of today's talk is going to be really bringing some of the evidence and learnings from the work that I have done and with a fantastic team, of course, working with me. And it's about how do you design these digital health innovations, specifically thinking about how they integrate into practice, thinking about scale, sustainability, and we are definitely going to focus on primary care today. And when I talk about these, it's not just virtual care. It is AI and AI that is emerging so fast and furious. And what are some of the considerations based on that? Just a little bit of about myself before we get started. So my background is health informatics as well as implementation science. And I've worked in Nova Scotia in the provincial health system and in research for many, many years, and many years within primary health care in Nova Scotia Health, and also as part of the Health Innovation Hub, working closely with Dr. Gail Tomlin Murphy, who is also listed here. She has been the PI and the lead working alongside with me on many of these implementations. And a lot of today, what I will share is really coming from that experience, looking from a health system context. But also more recently, my role now has shifted to the Dalhousie Pan American Healthcare Organization's World Health Organization Collaborating Center for Healthcare Workforce Planning and Research. That's a mouthful. But what we essentially do is we work with pan-Canadian organizations, with ministries of health. We also work in the Caribbean countries to really look at how healthcare workforce needs to really be updated and join the movement of the transformations that are happening, including digital health innovations. So I'll also bring that experience as I present today. I'd like to, if I can advance the slide here. Yes. So I'd like to start with a very important aspect is take a moment to acknowledge that Dalhousie University is on the traditional and unceded territory of the Mi'kmaq people and recognizes the importance of ongoing partnership, respect, and learning in the work we do. And with that in mind, I'll move into the outline for today's talk. So I'd like to set a little bit of the context of the type of work that we bring in the context of the discussion today. It's based on population health needs. Definitely want to talk a little bit about primary care and about health workforce. Then I'd like to talk a little bit about the emerging innovations in primary care that is on the digital health innovation side of things, and to really see how the impact of these innovations are. And then I'd like to take into a specific example on virtual care implementation within the context of a provincial health system. And this is important because it really brings that on the ground experience of what it takes to really integrate these solutions into practice. And then based on these, I'd like to look at some emerging considerations and some key insights. But more importantly, as Karen noted, I would like to spend some time to hear from you because I'm sure I'm not going to be addressing everything that you're looking for. So hopefully through your questions, we'll be able to answer that a little more. So moving to, sorry, need to go back here. This is the context setting that is important. When we work, especially from the collaborating center with multiple health systems, the important is to have a framework of reference. We plan in health systems, and I've been part of this. I've been a policymaker, decision maker, working in primary health care. The needs emerge so quickly. Oftentimes, we resort to the health workforce planning, which is probably outdated for many years. We are still counting the number of providers, the same type of healthcare professionals we need. And unfortunately, that's not the space we are in today. And so the population health needs-based planning framework that you see on the screen has been developed by Dr. Gail Tomlin Murphy and her colleagues. And the emphasis there is the dynamics of many different things that really needs to be driven by population health needs and how things change over a number of years for the population health needs, but also think about the intricacies within the health workforce planning space and what that means. Thinking about the types of providers you need, the dynamic of, the productivity measures, because that is so critical. But also, if you look at the circle around it, it talks about the socio-political economic context, including technological and geographical. And all of these have to come together in order for us to really understand how are we going to be planning for our health workforce, but more importantly, within the context of where will we be in the political policy, in the determinants of health that will drive these factors, as well as the technology innovations that need to be part of the planning. So we always use this as a foundational work that we bring. And at the end of the day, if we haven't impressed anything out of the implementations, we always talk about grounding the needs in the health of the population. And that's going to always keep us true to where we need to go. So I put this busy slide up, not so much for you to all see what we are doing, but in a way to see that where we are going with all of the requests that are coming through. The areas of focus have been, how do we do this planning? What does it look? Because the innovations, virtual, digital AI are emerging so quickly and integrating into practice. Team-based care and different types of professions are coming into play. So a lot of the work we're doing is really supporting organizations to do planning in a different way. So some of our publications are focused on that. A lot is focused on really bringing back to the basics to say, please look at the health needs of the population. We have done a lot of work in primary care on the integration of different types of solutions, including team-based care, virtual digital solutions. But more recently, we are also starting to work with cancer care, with the pan-Canadian cancer care agencies and provincial cancer care agencies to look at what are the innovations and how is that emerging and what are the impacts of those. So I just put that up because that's where we will be in the next few years, given all of the innovations that are happening. So let's look at primary care. I mean, primary care, primary health care, really we know the context of the population and what needs to happen. We are looking at multimorbidity, aging population, health promotion and prevention, and chronic disease. There's lots for us to do in Canada, and we know that there's our scorecards need to be better. We also know the current trend is getting care closer to home and in communities. And this is becoming a very big conversations in communities. People are, tired of traveling, and rightfully so. And especially primary care access is critical. And we need to see how we can enable that. We also know our emergency departments are not doing that great. We know that attachment is a hot topic for primary care. It is very critical and important. Anywhere we go, we are hearing about shortages of primary care providers. But I'll also say, and we all know this, attachment does not equal timely access to primary care. And that is where a lot of the conversations are. How can we make this happen in the right way? So it is integrated primary care. We shouldn't have, fragmented services, but at the same time, we do need to plan. And like I said, no matter how much we do, the broader topic is if we don't focus on the population needs, we're going to have unmet needs, we're going to have health inequities. So those have to be addressed. And we talk about the reason why we're doing all these innovations are because we need to enhance workforce capacity. However, in every implementation that I've been involved in, we always tend to forget how to support our health workforce, how to support the teams and support staff that are involved. So anything we introduce into the health system feels like one more thing that's added on to the workload. So we need to really figure out if we are planning to really support our health workforce and the capacity that they need, then when we implement digital innovation solutions, they should actually alleviate the strain and not add to it. So how are these workforce capacity considerations part of the process? That's been a big part of the exploration in everything we do. And we also want to think about, is it really aligned with the population needs? So for instance, in everything that we do, we have our patient community partners working alongside. And one of the things they add is they like the innovations, but they don't know how it fits into the broader scheme of things. It's always confusing to navigate, and we know that. So, from a workforce capacity, we should really know that it's not a temporary issue. It's not something that's fluctuating now. It's been a systemic, it's a structural issue. It's been there for many, many years. And anything we do should really support the capacity enhancement and not the other way around. So, when we look at the different types of innovations in primary care, and these are drawing from some of the published evidence, systematic reviews, there are many ways in which we are using technology, and we know that many of them are front facing to the community, consumers, and communities. So, we are looking at navigation. How do we use these to really bring the engagement of the communities and the patients? We are looking at ways in which culturally appropriate care, so the right type of community professionals can be part of the care process. And of course, how do we bring care closer to home? And so this is that value co-creation that's happening a lot, and rightfully so, these innovations are important. We also know that models of care, team-based care, interprofessional, integrated care, going into community long-term care settings are getting more importance. And this is also driven by some of the technology enhancements that we have, that we are able to actually get more access to people and professionals that we may not have had in the past. We know that financial, and the payment and those models are so important. And in most of the innovations that we have led, part of the conversation that should happen up front is how do we sustain this? What are the different aspects from policies, but also financial and payment models that need to support? But also, we forget in investing in the infrastructure and implementation supports that are critical for sustainability. So there are a lot of innovations that are happening in that space as well, especially in primary care, and we all know that. Technology and digital. So, many jurisdictions right now are talking about integrating their electronic medical records because, for all the right reasons, we have such disparate systems that part of the challenges that we encounter right at the outset, and nobody will be surprised here, it's about data access. And in order to not only implement a solution, but also to evaluate, we need to have right access to the data. And so the EMRs in primary care settings, we know they are so hard to get access to for the right reasons because they are linked to individual practices, primary care practices, to providers and different vendors. And so it's been the toughest thing to navigate. So some of the innovations that are happening is how to make those better, how to make the data platforms better, how to enhance virtual AI, of course, is in the forefront. So these are some of the innovations in primary care. Workforce redesign is critical. We know that There are many, many opportunities here to think beyond the usual types of professions we pay attention to, physicians and nurses, to now we are looking at community health workers, we are looking at pharmacists, we are using competencies to drive and shift the roles that need to change along with the types of requirements now. New competencies, as we look at digital health solutions, the type of competencies and the types of roles we need within health systems are also going to be very, very different. So, this has been a critical shift in the way the innovations are happening. So, workforce redesign is a core element in primary healthcare, especially because team based care is playing a very central role. And when we think about technology innovations, and I'll speak a little more to it, the types of roles are also different and the needs are different. So let's take virtual care because that's one of the areas that we were going to focus. So I'll start with kind of laying out some of the types of innovations in virtual care. And this can be, for instance, it is asynchronous, synchronous, video, phone based, and definitely in remote consultations and connecting people from remote communities, it has played a critical role. Virtual triage and monitoring and the front door access in primary care has been a key element of it. And in our example that I'll present, we did an on-demand consultations for low acuity primary care access using virtual care. And of course, the impacts right off the bat is improved access. People are happy that they can actually access care from home. They also see that it's an opportunity for some of the reasons why they shouldn't have to travel to get their access to primary care services from their community or from their home locations. There is, of course, with virtual care, varying evidence that are being shown in different types of publications, including ours. It's always very challenging. Is that, does virtual care really satisfy all of the needs? Does it really reduce emergency department utilization? Does it reduce in-person consultations? So there is varying evidence on this. Some of the challenges in virtual care is that the criteria for what is eligible for virtual care is still something that's being worked through, and especially because you're not in person, sometimes those cues, the visual cues, are not present. So there could be a risk of either over or under triage. Equity gaps can persist because you have to have the digital access. And so there are some people that'll get left behind. How do you navigate that? And much of the literature around this is still demonstrating the aspects of the specific innovation versus the overall integration of virtual care in the broader care. And that is going to be a critical area because even if we are trying to track the unintended consequences of these, such as ED utilization, we still don't know what the long term. You need to follow the patients to see if they are getting access in different ways past that initial consultation. So that's where some of our work has also focused in terms of virtual care. And of course, AI, artificial intelligence, is rapidly emerging, whether we want it or not, in different areas. And I believe it can have, and from everything, and all of us know, it's going to have a tremendous impact in primary health care. We know that AI scribes, primary care, is leading this space, and in many of the jurisdictions, they are well underway. Definitely in the scheduling space, as well as some of the clinical decision support space. Definitely in primary care, there's a lot of many examples of how things are shifting, and the focus has been absolutely, as many health systems are looking at, where are those low risk implementations. But as we know in AI, there's so many considerations to deeming something as low risk, and that's part of what is also unfolding in many ways, even with the AI scribe, some of the consenting and all of those process. But really the impacts are, yes, immediately you're looking at a reduction of the clinical workload, the administrative. There are efficiencies to be had in the scheduling process. And of course, there are some initial impacts on early screening, detection. But overall, I think there is more work, more efforts, because in everything that we see, in the readiness of health systems are the foundational standards. Some of the guardrails are yet to come in place. So things are moving so quickly in the space of AI that health systems are actually trying to figure out how those foundational elements, the foundational training, the awareness of risk, and all those are navigated before the confidence in actually deploying these solutions can take into effect. But also to keep in mind that AI, again, similar to any other innovation, in isolation, you don't see the true potential. So the roadmap that needs to be drawn to what is the way AI is going to integrate is a whole other layer that health systems have to work through. We also know that AIs are front-facing patients in many ways, and again, fantastic opportunities, to bring the type of self-management supports. And we have seen this in the mental health space, and what a big gap that it can fill. But again, there are symptom checkers, health advice, coaching, all of those are available. And the part of, the opportunity is that we can enhance things in so many ways. We can bring that, the health literacy, the coordination, probably even navigation supports. But again, the big challenge remains is, have we designed it in a way that it can really mitigate all of those risks that might come out of this reliance on AI tools? Do we know, even working with the vendors, the type of risks of the type of data that is stored? How do those permissions change and when? I think to all the conversations we have, even with simple Zoom sessions these days, do we really know what is being used, how it is being used? So those continue to play a big role, and in primary care, especially as the doorway into the health system, we need to be stronger as these opportunities emerge, and they are big opportunities, but they can also be the places where we risk without proper guardrails. So I just want to take some time to talk about, a neat opportunity to think about implementation and integration in a big way, because we had to do this province wide. And so this is about virtual care and more like on-demand virtual care within primary care for low acuity care needs, so that you're not waiting for an appointment, or it's not a virtual care from a practice instead of an in-person visit. This was actually from your home. You decide, you have a type of a need. It could be a UTI, it could be something that you need. And how do you now immediately access primary care? And I think many systems have gone here. But for us, the importance was to say, how is this not going to stand outside of primary care? How will this be integrated? So, part of our consideration in the outset, and this was important because we co designed with primary care providers, the primary care system leaders like managers and others who really know the front lines and what it needs, as well as patient and community partners. And an immediate recommendation was that virtual care is not about just virtual care. It's always going to be linked with in-person care. So we cannot think of these consultations in isolation. And these have to actually fill the need if it's going to go that way. And really identifying what are the ways in which we can triage these, and then what is the escalation protocol when in-person care is required. But then what is the scope of this? What type of visits will be seen? And then where do we draw the line? Then how do we help the person navigate? Because you can't just say, sorry, we can't do that. You have to have a follow-up. So it was really thought through very carefully. And we did a phased rollout. And this is where the implementation science, we need to think about this. We need to have more of this, because we did know that we're going to start with small areas. And that means what we learned from every zone had to translate to the next zone. So carefully evaluating what we needed to do and how we were going to do iterative improvements were going to be extremely important to us. As well as the thing we forget the most is implementation supports. So As we know, primary care system, as all other sectors in healthcare, so stretched. So we can't just say, here you go, we're going to do this. Now we're going to have people accessing your care in different ways. We had to provide those. So we actually created a program manager and, kind of those people from the front lines of primary healthcare to be part of the process, but as added supports to do this. And what was important to us is that this doesn't sit on the outside, but it was embedded as part of the primary care ecosystem, as being one more point of access. And because we had to navigate both attached and unattached, and I think people who are on the call need to know the differences. Attachment is having access to your regular primary care provider, and unattached is you don't, and you have other types of access. So we had to make sure that there was a follow-up care regardless of whether you were attached or unattached. We also established a quality safety advisory committee as we were rolling out because we wanted to consider, that there was oversight through the process. And we also had carefully thought through what if scenarios of where would people go, what would be, and we made sure the health system overall was aware of what was happening. And of course, alignment with the types of registries and others. Equity, again, I'll come back to this later, cannot be an afterthought. It is going to come, it should be part of your design. So we knew we were starting with people with certain types of access. So we knew going in we were already leaving out quite a few people along the way. So part of our consideration was that we need to work with community locations, community partners, because down the road this was going to be, and these were like libraries and other community accessible locations across the province. And it was really the relations that the primary healthcare system leaders held with their own communities that they were asked to start looking into it right from the outset. And so we addressed with this, kind of the digital literacy needs, connectivity needs, the access in those community locations, how people can come and receive care. So community partnerships were critical along the way. We also knew that sustainability had to be part of the planning. And even in the early phase of rollout, like I said, we had the oversight committee that was already in place, but we also had almost like the semblance of a provincial program office for virtual care with dedicated leadership structures. And this was important because, as all innovations happen and as we know, the political will to do things quickly. While we were rolling out for primary care, there was a big appetite to do the same thing for emergency department as virtual emergency care. So we had to ensure that there was a focus on what this brings and how we need to have the type of leadership to support it. So we had medical, clinical oversight, we had administrative oversight, and we had people, new roles like the technology support team that could help the clinicians or the booking staff in primary care to support this. And there were funding aligned to for the implementation as well as some of the financial kind of the remuneration process for the people who are involved, the providers. And for us, the biggest thing was that it was integrated within provincial primary health care suite of services so that for the patients, communities that are engaging in this care, there should not be any doubt as to this was being offered by the provincial health authority. So that was a big part of it. And having the new roles and really the digital infrastructure and, like I said, the ongoing evaluation monitoring was critical. So to have, as we're working with, as we do in the innovation space, we work with private industry partners and different vendors, but this should not be a deterrent to advance innovations. We just need to have the proper process of ensuring that the platforms that are integrated within the type of requirements that need to be followed, and they're not sitting outside of your health system. And we also had monitoring dashboards, utilization tracking. And it seems like a big deal for this, but it was important. And what coming out of this, the implementation, of course, we had problems all along the way. And of course, it's still evolving. And But the opportunity, as we do with many of our implementations, is even if you do, we will not be solving a lot of things overnight. But if we leave some of the foundations of how these continue to evolve, that has the right type of I say the guardrails, like the oversight structures. They are integrated within the system and how we provide care. And we have the provider and community voice, because we had the providers have a committee so they could onboard, orient new providers coming onto this. And I think the opportunity is to continue to hear from the people who are using the service, so that it doesn't have to be elaborate feedback. It doesn't have to be an elaborate evaluation. I don't think anyone has the capacity or the budget to do those, but you have to narrow down your metrics. Once you have evaluated the initial rollout, you have to have those narrow metrics that will continue to inform you if things are going, like as simple as, if people are giving you low rating, something is wrong. So then you have to have a plan to say what happened, what's going on here. So would you go into a qualitative evaluation phase to understand why things may not be going? So as simple as that, but it has to be there, those checks and balances. So coming out of this, while the challenges will continue, because it's primary care and you have to be able to understand where virtual care can and where it cannot be the be all end all for everything, how every, and as we found out, for the number of virtual care consultations, at least 20 to 25% result in in-person care. And you have to be prepared, because again, from an overstretched system, you can't just expect that this will automatically happen. So it has to be built into the design. You have to build into the design the equity aspects of it and how you might address that. So those were some of the considerations coming out of this implementation, which has really been a roadmap for many of our other virtual digital implementations. And as we work beyond the province and at the pan-Canadian level, these are the considerations that continue to come. So I'll carry on to say, across all of these innovations, even be it, of course, digital health innovations, there are specific types of needs. But if we look across innovations, the overarching things are, if you have the proper type of needs guiding the process, that is the population health needs, that should be where we say, and there'll be nuances by community. So, what are the needs? And based on the needs, what type of services are you offering? For the types of services, what type of competencies do you need? And where do digital solutions? And definitely, when we look at the integrated health data needs, for all of these solutions, especially with AI coming so strongly, the challenge is the access to data. And I think this is where the partnerships have to get stronger. And that's some of the things I'll speak to very quickly in the next few slides. But also the acknowledgement that it is intersectoral. So our health workforce planning has to shift to see what kind of partnerships. And when we start to think about determinants of health, and when we think about all of these are care in the communities, we have to really think about the type of data that will help us plan in the right way. And that means we have to have those relations and permissions in place to work with the communities, to work with other sectors. And we're really thinking about health and care workforce. So, really, we are thinking about care beyond our health system. So, what is the way we think about that? What are the policy levers? And equity has to be by design, and that's critical. So, really, when you think about primary health care, which is where I think is the most challenging to access the health data because of the way in which it is extremely fragmented. The access is challenging. The quality of data is also something that we need to work towards, because some of the standards are not always in place. And so when you think about extracting data from EMRs, we need to really think about how much is text-based. And that's where, of course, AI will play a critical role. But we need to start thinking about how we're going to work to have the data access within primary care environment. And we are doing some of that work with the ministries of health and others to see how we can really support that. We also know that privacy, security, the governance, as I said, these are for the right reasons challenging. So that means upfront we have to start thinking about what type of agreements, what type of consenting process, even as we think about AI scribes and the examples of that, it's going to be important that those are navigated. And we have to think in the world of digital and AI, what type of layers of sensitive data. So not all applications will need the type of data. So, what can be low risk versus what is high risk, and how do you define, how do you standardize that? That is going to be very important because I think in talking to patients and communities, I think it's a transparency of how this is going to unfold. The trust that we build is foundational, and so that's going to be critical in navigating the data needs for this. And can't stress enough that workforce has to be a central planning consideration because as we are changing so quickly, the redesign of workforce, reimagining of workforce, the change management, the investments and capacity enhancements are so critical. And we see the role changes not only from technology front facing roles that will change, the roles that will change for the clinicians because of the type of technology inclusions. And what does that mean? For the support staff, what does that mean? As well, how will we support the community and the patients to understand what's changing? So, what type of roles will front face the communities? And that's going to be critical as well. And we know that the changes will impact how healthcare professionals and teams function. So, how do you change the scopes of practice? And ultimately, I think what is the value proposition for the healthcare teams? So, they need to understand clearly that are these enablers and they are not replacing the workforce, they are really redesigning the workforce. But how do you establish that upfront? There's a lot of anxiety around AI as they're coming, especially from an administrative front. And we just need to be able to work through and have the roadmap ready. Policy levers for scale, critical. So we have different types of payment model, different types of incentives. We need to think about payment structures for different types of professionals, not just the ones that work within the health system, outside of it, because that's where we will be in the next few years. The infrastructure, and this is where, from an equity standpoint, we have to think about the infrastructure, not just in the place where people access or where we talk about or the investments come through, but in those communities where we are going to have challenges in bringing digital and virtual and other solutions. What type of needs and how do we really prepare for that? What are the standards? What is the education training? What type of partnerships will we need? And how do we really support this long term? So, part of our learning was that as we were implementing things in real time, we were also feeding to a certain audience that was going to continue to fund them so that these types of innovations don't stop. I've had multiple times when you have to explain to patients why this is of no interest anymore. Because when you provide access to a service, patients and communities come to think it's part of care. So you can't just have innovations one day and say, too bad, the pilot has ended now and that's over. So we'll have to really think about how do you demonstrate the success, even if you have to pivot and change, you're still bringing something because it's going to bring value. It's driven by evidence. So that's where implementation, it may not fit all communities the same way, but you got to figure out how you adjust that. So that's important. Equity should not be an afterthought. It should be designed. You need to have metrics in place that will guide your roadmap of how any innovation is going to, and digital is going to be a very big aspect of how it can increase the equity divide. And so, what will that look like right from the outset? And of course, as we think about digital and AI, how do we also mitigate those biases, and how do we really navigate those through those? And how do you bring a table that can actually help you navigate this? So it is not going to be easy, but you need to have the right people at the table talking through this. And that's the biggest thing we work through from our collaborating center. If nothing, let's leave the right table behind with the people who can actually continue to have discussions and have those conversations that need to happen. And, I bring this back because I think this framework is really important. Uh, if nothing, we always say the roadmap should go back to the basics of thinking about population health needs that drives all of the planning and the design over the next few years. And we should always design for scale. We should not we and the risk of having many pilots is that then these innovations will stall. So, and once something does not go the right way, it's hard to get the buy-in to do it again. So the design is important, and embedding workforce capacity and redesign is a critical aspect of this work and should be an important consideration. um, Alignment with policy, having the right governance, partnerships, and as I said, enhancing the how we design for equity, thinking about the metrics. And of course, we need to continue to invest in implementation and evaluation capacity. This is going to be so critical because part of our in our work in cancer care as well as in primary care is that um, the evidence always falls short on helping us understand how to scale something, and that's because we've not invested in really learning to the extent we need to from an implementation science view to say how can we actually scale this to different communities, how can it really reach all communities, which is usually the focus of that. So that's going to be critical. And I'm going to say that I've done all the talking. I'm hoping to have lots of questions so I can answer things that I'm not. But I really thank you for an amazing opportunity.